Hi everyone. Hi, I'm Dane, one of the PGY4s, and today I want to talk to you guys about using the clinical decision rule versus a imaging decision rule to predict non-traumatic hemorrhage in the setting of a negative CT. So 1 to 4% of our headaches that we see in the ED are due to subarachnoids, and 80% of these are due to aneurysms. What makes this diagnosis challenging is that a lot of these patients that we see in the ED have a normal neurological exam. Because of this, the article that I read says that we're missing 5 to 12% of subarachnoids. The standard practice is to get a head CT if you're suspicious, and then follow that up. If the CT is negative, follow that up by LP. And with that, you have 100% sensitivity with LP, CT combined. So the first decision rule I'm going to talk about is the clinical decision rule, which states that if you have any of the following combinations, you should highly suspect it and perhaps go on to more testing. So 1, age greater than 40, neck stiffness, loss of consciousness, and what I call headache angina is with headaches with exertion. And the other rule is the imaging decision rule, which says that if the CT head is done within 6 hours, that's good enough and you can stop there. So the methods of this study, it was a case-controlled study done through a review of charts. And the inclusion criteria, they use ICD-9 to diagnosis of subarachnoids, and plus a non-con CT and LP done during that ED visit. The patients have to be greater than 18, negative head CT during that visit, normal neurological exam, and RBCs greater than 5. And then this study that they did, they were able to include 55 patients. The exclusion criteria is if the patient has known aneurysm or malformation, if the LP was done before the CT, or if they had head trauma within the last 4 weeks. So after using the screening and inclusion criteria, they were able to identify 55 patients. And this was done by 2 ED docs that went through the charts and selected these patients. So in terms of results, they found that the clinical decision rule, age greater than 40, angina, headache, loss of consciousness, neck stiffness, had a 97% sensitivity, which I thought was pretty good. Compared to the imaging rule, which says image the patient within the first 6 hours and stop there, except the studies showing that if you use the imaging decision rule, you're missing 20% of patients with subarachnoids. And the table below shows the demographics of the patients that were missed. And you saw that on the when they did the LP, these patients clearly had evidence of subarachnoids, even though their CTs were negative. And they also provided angiography results further confirming the diagnosis. So in conclusion, a lot of practices are actually using this clinical decision rules to determine whether or not we should be stopping at the head CT. So the whole purpose is, okay, this person comes in, they have a headache, you're concerned for a subarachnoid, the head CT is negative. Should we now proceed after that? And if we use the clinical decision rule, it'll maybe reduce the amount of LPs we're doing. And that's one of the main points of this lecture. And it's also saying that the head CT done within 6 hours is just not good enough because we're missing 20%. That's it. These are my references.